Brilliant. Lots of people here today. So welcome everybody. Good afternoon. I'm Joe Culliford, Director of Smart Data Research UK. Welcome to this webinar about using internet search data to improve health research. And we're delighted to be co-hosting this with Google Health this afternoon. And it's the first of a series of events that Smart Data Research UK is planning to organise with partners to explore the opportunities to use new and emerging forms of data for research. And I want to start by just saying a brief word about our programme at Smart Data Research UK. So we are a new UKRI investment to unlock the power of smart data to improve lives. And what we mean by smart data is all data that's being generated as a result of our digital interactions through apps on our phones, social media, banking, wearables, sat navs, and of course through the activities that take place on the internet. So what we're doing is we're funding the creation of new data infrastructure that will make it easier for researchers to access and use smart data, and make it easier for companies that hold smart data sets to share those securely with researchers, and to do so in a way which maintains public trust and generates social and economic benefits. Now, I'm delighted to be joined today by a really exciting panel of speakers. So we have Dr. Susan Thomas, who is UK Director at Google Health, Jessie Chewy-Chavez, who is the Engineering Manager of the Data Liberation Team at Google, and Professor Matthew Thompson, who is a Clinical Research Scientist at Google Health. And I should say Chewy and Matthew are joining us from Chicago and Seattle, respectively. So special thanks to them for making a slightly earlier start to be with us today. I can see Matthew sipping on his coffee, which I hope is nice and strong. So closest to home, we have got Dr. Surgeon Saiso, who's a consultant gynecologist and gynecological cancer surgeon at Queen Charlotte's Hospital, and Professor Emmanuel Tranos, who is Professor of Quantitative Human Geography at the University of Bristol. And I also have colleagues from the Smart Data Research team here, including Rochelle Ranshod, who is going to be helping us to sift through the questions that hopefully will be coming in from the audience throughout the presentations. I'm going to hand over to Susan in just a minute. Before I do, just a couple of housekeeping things to say. First point is that this webinar is currently being recorded and will be available to watch again on our YouTube channel. Please do post any questions that you have in the Q&A function. We're not going to be able to pick up any questions that you put into the chat function, so just make sure you're putting them into the Q&A function. If you have a particular speaker in mind for your question, then it would be very helpful if you could indicate that too. And we will try and get through as many of your questions as we can, although our times are quite tight for the webinar. So I'm plea to our panelists to try to keep their presentations concise as well. Now, I think that's everything I need to say. So I'm just going to pass over now to Susan.
Thank you for that, Joe. I'm Susan Thomas, as Joe said, Director for Google Health for the UK. And I just wanted to say a very short thank you to Smart Data Research for inviting us to come and co-present this webinar. Google Health is really proud of the deep and important relationships we've developed with the UK health research community over recent years, particularly around smart data. We've really focused to date on wearables and devices, been focusing on how can we look at those in care pathways and so on, and really sort of changing the way we think about those data. But we're really excited now we've got this new tool in our toolkit of what we can do with internet search histories. Surgeon's going to speak about the research he's done into gynecological cancer, and that really brings it to light. So I'm delighted now to hand over to Chewy, who's going to take you through actually what is takeout data and how can it be helpful. Thank you, Chewy.
Awesome. Thank you, Susan. Again, my name is Jessie Chewy-Chavez. I'm one of the managers on the data liberation team within the privacy, safety, and security organization at Google. I'm going to speak a little bit about our data portability tools, what we've built over the years, and one thing that has actually been released, it's very new, and talk a little bit about the data that's available for this use. And so really excited about data portability in general, but especially when it's used for helpful causes such as what we're talking about here today. So we are been around over 15 years, starting with a few small products, making them available in a portable, machine-readable format. Along the years, as the Google product suite has grown, so has our tool, and now we're over 80 products inside Takeout. And then just recently, as you see our last point there, we launched a data portability API. So I'll actually talk a little bit about that in a few slides. Next slide. So the main purpose of Takeout is to give users control over their data for uses such as research, personal backup, etc. It's a centralized tool, as I mentioned, with over 80 products. And you're able to get a copy of your data at Google from the data you have provided, photos and account information, ratings, and saved maps, all the way to stuff that you've generated along the use of Google products, such as your queries and visit data inside search. We also allow you to transfer that data either to competing services or to backup services such as Dropbox and OneDrive, etc. Next slide. For the Takeout tool, which is a user-facing tool, any and all of you who have Google accounts can go ahead and log in at any time and use it if you'd like. You'll see the list of products and what data you would want to include. You might actually be surprised sometimes, like, oh, I wrote a blog, 10 years ago, and that data should be available and surfaced inside Takeout. You can decide if you want to do this kind of backup or export of your data at a more kind of frequent interval. And you can also choose the formats around your data. You might want something in DocX, or you might want it in OpenDocs, for example, for documents, or you might want things in PDFs. All of that is a choice that we offer you within the Takeout tool. Next slide. You can also customize the experience around a Takeout. You can choose specific data within different data sets. So, for example, my activity is your activity inside web search, but there's also activity inside YouTube when you search or click or view a video, on Google Assistant, on other surfaces. We allow you to choose a subset or all of that data. And then again, the destination of where you want to send it to and how frequent you want to send it. Next slide. A popular use of the tool is to actually send that data up to a drop zone. That drop zone can be an external provider such as Box or Dropbox, or it could be like Google Drive. From there, it's relatively easy to do a one-click share of that data to a researcher or to another account that you might have, wherever you want to actually send it, it's in control of the user. Once it's out and captured and shared to a drop zone, it's a very easy one-click share from there, and we see that as a popular use case as well. So that's one way of sharing out data to a third party. Next slide. But to make it a little bit easier, so all of that is a user-facing tool. So Takeout is you as a user, the end user goes in, selects the data, selects the frequency of export, selects where they want to send it to, and then shares it out from there. To actually kind of simplify that third party sharing of this data, we built what's called an API. I think anyone who is technical might understand what an API is, but I think almost all of you have interacted with an API. When you say something like share my contacts with my tool, share my photos with, etc. When you allow access to your location, etc., you're allowing an API to be used. So we built an API around the data that's available in Takeout, around some of that data. And instead of the user having to go log in and then make all these choices and then send the export out, a developer, a third party, say a research institution or a popular health tool or a tracking tool, can actually prompt the user for those same choices, but on behalf of from the tool, from the surface of the tool. So the app can say, please share this data, and the user will be directed to this flow here. So if they'd have to sign into their account, and then they'll be prompted to share the data, confirm it, and then they can choose which data they'd like to share or not share. So that's a much easier flow than requiring the user to follow a set of instructions. Both are options for the user to share data, but in this case, this reduces the steps down, and the developer, or in this case, perhaps the research tool or app, will make the kind of define the choices for the user, and then the user just goes in and confirms access. Next slide. For those who are even want to dive even deeper into the technical stack, we created an open source tool around this data. It is open to
I think are we losing Jesse slightly? I wonder if we are going to have a problem with your connection. Maybe we could.
I could talk to this just while Chu's getting back on. This is the data transfer project is an initiative that's spanning many of the companies. You can see the logos down there: Google, Apple, Facebook, Microsoft, to try and improve this connectivity of different companies' data, rather than having a bespoke system that only work for Apple or Google or Twitter, that type of thing. So it's to try and make this easier, a bit like telephone exchanges came in many years ago, to exchange telephone calls between different kinds of companies. Maybe look at the next slide here. I think he's only got a couple more slides. Oh,
I'm sorry.
Go.
So
Go
sorry.
ahead.
Zoom got frozen. Thank you. And then so kind of to compare the two options that I just spoke about, the takeout end user tool and the data portability API. Kind of to reiterate, the takeout tool is an end user product. It requires the user to interact more intimately with the tool. The data portability API is a developer product, so it puts the control in the developer as to what the flow should be, what data should be requested. Takeout has been available globally for some time. The data portability API has just rolled out since March in EU, UK, Switzerland. There's a lot more products available in Takeout right now. The API has 8 major product areas, which cover a large set and the most useful set of the Takeout data. But that's what's currently available until we expand. And then both are machine readable, stuff like JSON files, etc. But the API makes it easier to take those JSON files and easily start parsing right away. So again, it's a developer-facing tool. Next slide. Awesome. So just to briefly take a look at some of the data, we'll take one of the most popular uses of data for research, which is search data. So whether you're using a takeout tool to download the information, or whether you are using the API to obtain it, what you will at the end have as a researcher or third party, you will have a section of JSON code with this kind of example. You will have the heading, which is what search data versus a YouTube search data. The title, which includes what is actually visited or searched for. The URL, which is definitely helpful to understand what exactly was visited. The time it took place, which could be really interesting when a user actually places a search. The products included, this could be like Google Assistant or your Google Home, etc. And then finally, what activity controls are in scope. We offer several ways of managing your activity, what to turn on, what to turn off, and we just reference those here. Well, so this would be the structured information you would get regardless of which surface you interact with to obtain it. Next slide. One before, I believe. Oh yeah, there it is. Okay, awesome. So real quick, this is where you search data, right? The good old familiar Google search, the simplest user interface on the planet. And so at the time that you make the search as a logged in user, that activity is available to be exported. So literally you can make a search and then go to take out as the next screen, do an export. Search query that you just did or visited will be
Chewy's breaking up a little bit there. I think what this is showing is basically immediately you put something in your search button or the Omni button at the top of the screen there. This is showing up immediately, and you as a user, you can choose what you want to save and what you want to export, whether it's your search history, YouTube history, etc., etc. is under your control. Next slide. And this is independent of which browser you're using, Chrome, Safari, someone else's, whether it's your mobile device, your desktop, and what operating system. Next slide. Perfect segue to introduce myself and Matthew Thompson. I'm a GP, professor of family medicine, and I work at Google Health, and I'm far better talking about medical research than technical issues of engineering. So happy to transition onto this section. And I've got two goals here. First is, where do I see internet search data providing particularly unique value for medical researchers? And secondly, how have researchers used this type of data so far? Next slide. So here's a typical diagnostic journey that people go through from first developing symptoms, changes in behavior. Those evolve over time. They eventually go to their GP, the A&E, and seek care, often several times. Eventually referred for specialty care, investigations, diagnostic testing, and finally intervention. And there's two issues with this type of pathway. Firstly, there's often a very long time interval for many conditions, from the very first changes people notice to diagnosis. And then secondly, we have, in many cases, a very limited evidence base to inform changes to our care pathways, information for patients, doctors, NICE guidelines, that type of thing. Next slide. So this is where I and others see particular value for the potential of internet search to try and improve these earlier stages of detection of many serious health conditions. Next slide. So here's an example of lung cancer. Just go back one slide. So lung cancer, as you know, is one of the most prominent causes of cancer-related death in the UK and many other countries. It's a cancer where the time from the first symptoms that we note in GP records to diagnosis can be as long as 6 months, often involving several GP contacts. And this matters. Survival is very closely linked to stage at diagnosis, as you can see here. Next slide. So where do researchers currently find data about disease presentation, diagnosis, and prognosis? There's been a vast amount of data that uses data after contact with healthcare settings, often GP records or hospital records, and that's been very, very fruitful. Next slide. Far fewer studies have been able to look at data before people contact healthcare or their general practitioner. Yes, there's been surveys or interviews with patients, caregivers, loved ones. So for lung cancer, for example, the time from us first seeing symptoms to diagnosis can be about 6 months in the GP records. But if you ask patients, survivors, caregivers, they often remark that over a year before they're diagnosed, they were feeling something wrong. Something was beginning to feel wrong to them. Next slide. So here's where we see the particular potential value of internet search data is in this early stages of people's diagnostic journeys. So as we know, searching the internet is a very common part of many, maybe most people's healthcare journeys. It's private, it's inwardly facing. You're searching about yourself usually, or a loved one. And it's contemporaneous. There's no recall bias. There's no looking back issues. And the hypothesis is that data from individuals' internet searches could provide a unique missing piece in the health research data types that we've been searching for or wanting for diagnostic research. Next slide. So what have researchers found so far? This is a fairly new area of research, and we recently completed a systematic review with colleagues at Imperial College London on the use of internet search data for diagnosis and prognosis. We found 23 studies which had used internet search data. About half had used Bing and their very large anonymous backend database. A half had used Google's takeout or Google search data. These were typically smaller studies involving individual consent and linking people's Google search data to their medical records. I should point out these data types are very different from the Google Trends or the very large aggregated data types that we'll hear about later in the presentation. These were people's individual search histories, either anonymized in terms of Bing or with consent in terms of Google. Most studies were from the US. There's only been one study from the UK, and we'll be hearing from Dr. Sasso in just a moment. Huge range of numbers of participants from fairly small pilot studies to the very large thousands of participants found in some of the Bing studies. If you look at the conditions of interest here, these are the areas of health that our healthcare system struggles to diagnose, for example, pancreatic cancer, Parkinson's disease, or diagnosis late, and others where we have very limited tools to predict events, for example, predicting suicide events. So you can see the researchers have picked up on the particularly important health challenges. What have the studies found? In general, there is promising initial evidence using just internet search data for diagnosis and prediction. But it's fair to say this is a new area of research and a new data type. Most studies have only had one publication on one disease. So we need to validate the findings of these initial studies. It seems important, maybe critical, to link individual searches with their medical record data so you really know who has and who has not got a disease. I think thirdly, there's the question still unanswered is what is the exact utility of this kind of data? Most studies have been retrospective. Could we imagine using this kind of data prospectively to inform care pathways? And lastly, some issues perhaps with consent and making this type of tool equitable across different populations. So let me stop there, and I'm really pleased to introduce Dr. Sasso, who is going to talk about his study, the only UK study on GYN malignancies. Dr. Sasso.
Thank you very much for that introduction. Hello, everybody. Delighted to be here, and thank you very much for this invite. I'm sorry that I'm dressed like this. I've been operating all day. I'm a gynecological cancer surgeon at Imperial College London, and if studies like this become successful one day in the future, perhaps my job will be obsolete. So let's kick off. Next slide, please. A little bit about background. So gynecological cancer that we focused on, two cancers, ovarian cancer and endometrial cancer. Ovarian cancer remains the most lethal gynecological malignancy, largely because most women present with advanced stage disease. Endometrial cancer is the commonest gynecological malignancy in the UK, with a rapidly increasing incidence driven by the obesity epidemic. Next click. And another click. So no screening program in place exists for these two cancers at present. Like, for example, with cervical cancer. In a perfect world, if we did have a screening program, it would probably depend on symptom detection and on primary care imaging. Next slide, please. So what is the importance of early detection of disease? We know that ovarian cancer has a 5-year survival rate. 2 out of 3 women are diagnosed with advanced stage disease, and advanced stage disease has limited treatment options. So about 2/3 of women are not suitable for any treatment, which is a disaster. Next slide, please. We know that earlier cancer detection relies upon prompt referral for investigation of symptomatic individuals and periodic screening of the asymptomatic population. So if you were found to have certain symptoms, what would you do as a patient? You would go to your GP, your primary healthcare provider. The GP would then identify the patient as high risk and then refer for imaging, blood tests, and secondary care for further investigations. The problem with ovarian cancer is that these symptoms are non-specific and vague, and there is poor awareness of its presentation among the general population. This all contributes to delayed diagnosis. We also have referral barriers within primary care. Key contributor to delayed cancer diagnosis, as women typically present to those primary care providers 3 times before being referred on average. There's also lack of experience. It's a relatively rare condition. 1 in 70 women will get ovarian cancer, so your average GP will see 1 case in 5 years. Next slide, please. We therefore need to look at alternative pathways, and what I'm interested in is how we can use artificial intelligence, machine learning, and data to bring about a faster diagnosis, so taking us away a little bit away from ultrasound, tumor markers, etc. We know, so what is this area that kind of brought about this study? What is the big theme? It's the theme of digital footprints. They've been shown to be useful in disease surveillance and for generating individual health risk profiles. They're non-episodic, they tend to be temporarily dense, and then they can complement, therefore, a conventional method of disease detection using sparse episodic healthcare records. 2 studies, just to give an example. We've got the study by White et al., which looked at lung cancer, 4 million searches related to lung cancer, 5,000 individuals went to look for lung cancer diagnosis, with a potential, therefore, to predict lung cancer in 58% of cases, 39 weeks before the clinical diagnosis. However, only proxy diagnoses were used here, therefore not actual histological confirmation. The other study was the CLOCK study. This was a study also done at Imperial College, looked at shopping habits in women with ovarian cancer and healthy controls. What they found was that there was an increase with regards to purchase pain and indigestion in medication. So the purchasing of pain and indigestion medication in women with ovarian cancer 8 months in advance of diagnosis. Again, something of interest. Next slide. So based on these 2 studies, and some others, of course, but we aim to appraise online search patterns in symptomatic individuals with a known gynecological diagnosis to determine, number 1, if there is a difference in online search patterns between individuals with a malignant and benign diagnosis, and 2, if this can therefore enable the identification of individuals with a gynecological malignancy at an earlier stage. Next slide. This was a publication recently in BMC, which we're obviously very happy and proud of. Let's discuss the methods a little bit. So next slide, please. With regards to methodology, we did a prospective cohort study evaluating online search data only in symptomatic individuals. So there's those individuals that were presenting to their GP and were Google users. They were referred from primary care with a suspected cancer to a London hospital between 2020 and 2022. Informed consent was obtained, and then we used Google Takeout as explained in the first talk. Next slide, please. A health filter was applied to extract health-related terms for 24 months prior to GP referral. We used an area under the ROC curve to evaluate model performance. In terms of numbers, 844 women were approached, 652 were eligible, and 392 were recruited. We had a cohort of 235, which we used for our study at the end. So not huge, but at the same time, a decent number to act as a pilot study. Next slide, please. This was the questionnaire that we used, just so you can see, very simple, in order to extract data parallel to the study from all patients. And next slide, please. So this just focuses a little bit on our results. The cohort had a median of 53 years and a malignancy rate of 26%. Vast majority were ovarian cancer cases. The rest were, as explained earlier, endometrial cancer. Next slide, please. Thank you. So just to look at some of our results. So first of all, this is the first clinical pilot study to demonstrate the feasibility of using online search histories in individuals with a known and confirmed gynecological diagnosis and pathology as a potential disease detection tool. Our study suggests that screening based on online search data may provide a signal of disease. up to 360 days prior to primary care. Sorry, next click, please. So up to 360 days prior to primary care referral with an AUC of 0.64. Obviously, this gradually improves closer to the GP referral date. The best performing model had a sample size adjusted of 0.82 in users who engaged in health-related surgeries up to 60 days prior to the GP referral. Next slide, please. Furthermore, sorry, if you go back a slide. Sorry, apologies. No, that's fine. Sorry. Yep, that's fine. Thank you. Just to say, we also, as a control group, used a big population of 1.8 million users between a year, so between 12 months, female and male. And why we needed a much bigger control than what we had in our study, because ultimately our study, the control is just the section of the benign population. Interestingly, the search terms of Bing control group mirrors our benign group, with a typically low classification score suggesting the absence of malignancy. Next slide, please. And then one more click. So next click. This is just to say, in terms of a kind of a subgroup analysis, we found that online search data provided insight into the presentation of gynecological cancer with an increased frequency and severity of urinary and gastrointestinal symptoms noted around 140 days, and menopausal symptoms and pain around 70 days in advance of the GP referral. So it was interesting on that level as well. Next click, please. So to conclude, first study to demonstrate the potential role of online search data. Predicted performance did vary depending on whether categorical or categorized search terms were used. The best search terms-based model had a comparable performance to established disease screening programs, such as cervical cancer, which is interesting. However, obviously, further research is required to evaluate the performance of the online search model within a larger cohort. Other matters of interest is that, I mean, it's obvious to say, but we have confirmation, I guess, that women do go onto the internet to inquire about their health, and especially when they have symptoms, when they're concerned, and there is a delay before they present to their doctor. And the other matter of interest was we had a lot of concern whether this would pass ethics. Once we got past ethics, we were then concerned whether patients would agree. Actually, we found it very easy to recruit women because patients were aware they were willing to give up their internet data as this was for health-related reasons. So to conclude, to further evaluate the diagnostic capability of online search data in the early detection of disease, we aim to do a multi-center study to improve the overall performance and generalizability of the model to the general population. Next slide, please. Thank you very much. And this is obviously, at the end of each talk, I always thank the people with whom I collaborate and without whom I wouldn't be here presenting these results. Thank you very much.
Thanks, Sergio. So we're going to go straight over to Emmanuel now before we open it up for the questions.
Hello, everybody. Thank you for having me here. My name is Emmanuel Tranos. I'm a professor of quantitative human geography and probably the least medical expert in this panel. So what I will try to do in the next few minutes is to infer the potential of these data for social science research. And let me try to make the claim that this discussion is not entirely new. So next slide, please. I will try to go back to the distant year of 2006. Next slide, please. When our friends from Google introduced Google Trends. I'm sure most of you are familiar with this service. Google Trends is a website, it's a service that is operated by Google and allows individuals to make some sort of analysis regarding trending search terms. And individuals can analyze such search terms and how they evolved over time and over space. Of course, this is an aggregated group of indicators, and I underline the term aggregated here. The analysis can only take place at a very coarse geographical scale. It's fully anonymized. We're just observing, broader societal terms, if you want. But this was very, very successful and still active until today. Next slide, please. You can actually go on Google Trends website and just explore what the UK population is searching for right now, as Google highlights. Next slide, please. A side product of this service was the whole discussion around Google Flu Trends. So a couple of years later, in 2008, Google introduced another web service called Flu Trends. And actually, this was the outcome of some form of modeling exercise. The idea was quite close to, well, of course, much more simplified to the discussion with the previous presentations. They used search terms in a way, or variables, using search terms in order to build an early warning system for flu outbreaks. This study, generated a whole lot of discussions about the accuracy of these tests, but I think we can all agree that it actually was a breakthrough moment. And even until today, we have a lot of studies being published within the medical world, utilize similar form of ideas to make certain predictions, nowcasting, early warning systems of various types of outbreaks. And we saw similar things during the pandemic as well. Google Flu Trends is not available anymore. But next slide, please. We have a lot of research within the broader social sciences domain, which utilize such aggregated Google search type of data. And the fact that in 2018, we had a paper reviewing this type of work, I think is illustrative of how important this data contribution was in this domain. One of the things that this paper illustrated, next slide, please, was these groups or typologies, if you prefer, of research fields that utilized such Google Trends data to answer a variety of research questions. So we can see, if we dig into this literature, we can find papers from the information systems and computer science. We can find, of course, a lot of papers from the medical and bioscience domain, but we can also find papers from economics, business, and other fields. And this is the area that is more familiar to my research, if you prefer. Next slide, please. And I have here on the screen a paper which came out in 2013 by Price and colleagues. And what they did was to use such Google Trends data in order to build an early warning system for changes in the stock market. And I do remember when this paper came out and how well it was received from the community, but there is still a discussion about the predictability of these of tools based on such data. Nevertheless, this is indicative of a whole new stream of research that utilize such aggregated internet search data to build models that can nowcast, do some sort of short-term prediction, or build early warning systems for a variety of societal phenomena. Next slide, please. The paper which is closest to my own interest is this paper from De Vriend et al. From 2011. And what they did was something very, very simple. They utilized the Google search engine and they actually created a script which allowed them to search for web content that includes a variety, well, that includes the names of the most important cities in the world. And they used, this idea, this framework, in order to build indicators regarding the importance of various cities around the world, but also regarding the connectivity, the flows between such cities. So again, that was another idea, another application of utilizing web search data at an aggregated level. Next slide, please. And this is the common line. This is the common point in all of these small social science type of work. I try to summarize the last few minutes. Next slide, please. But now we're moving to something much more exciting, and everything that we talk about today from the previous speakers had to do with individual web searches. And I think this opens up a great number of opportunities for social science research. I would have tried to create a list of the topics that such data can help us approach or research questions that we can answer. But I'm afraid that this is not an easy task. And it's not an easy task because the list or the range of topics that we can approach using such data is, in essence, as broad as the web itself. I can very easily see the potential of such data to help us, understand consumer behavior, help us conduct political studies, help us understand various dimensions of mobility, for example. In essence, such data can help us make inferences about interactions between individuals and institutions or organizations, or the perception of individuals about institutions and organizations. An important element of these studies, and I think the previous speaker also highlighted this, is the recruitment of individuals who would like to donate their data for this research. So I think for that reason, I foresee better or more easier usage of such data for rich studies of small sample. This contradicts, if you prefer, a movement that was quite popular within the social science domains during the last 10-15 years, of studies that's approaching the whole range of population. But of course, this is not problematic at all. It's still very useful if we are able to create meaningful, small, well-curated samples populations that fit the specific research questions we need to answer. It might be difficult to scale up, but this doesn't take away the value, if you prefer, of such data. An important element that needs to be highlighted has to do with filtering the web histories of people who donate such data. And I believe the paper from the previous speaker from Bartford and colleagues offered a very interesting approach on how to filter web histories in order to focus only on topics that the research project is interested in focusing upon. And last but not least, it's the ethical challenge. The ethical challenge of linking some of these web histories with some form of individual attributes about demographics, attributes about the broad location of individuals. This is an ethical challenge but at the same time can lead to some fruitful results. And I think I'm gonna stop here. Joe, the microphone is back to you.
Thank you so much, Emmanuel, and thank you all the panelists. So that concludes our presentation section of the webinar. We'll stop recording now and move on to the Q&A